Hello, my name is Pete Melrose, an independent information technology or IT consultant to professional and organizational healthcare providers, typically doctors and hospitals. I appreciate this opportunity to present the Cloud Healthcare Appliance Real-Time Solution as a Service, or CHARTSaaS. CHARTSaaS is a copyrighted IT solution to the problem of medical mistakes, which problem currently is the third leading cause of patient deaths in the United States of America. IT-enabled real-time cognitive support for medical mistake mitigation will facilitate the long overdue need for transformation of medical practice and healthcare delivery. I appreciate your time and consideration, and I hope for your support in completing CHARTSaaS development for the benefit of professional and organizational healthcare providers and their patients, all of us. The agenda for this presentation includes 4 parts: healthcare provider problems and medical mistakes, mistake mitigation with Cloud Healthcare Appliance Real-Time Solution as a Service, or CHARTSaaS, CHARTSaaS components and proof of concept, and CHARTSaaS call to action for interested parties. Medical practice and healthcare delivery pose several substantive problems for professional and organizational healthcare providers, which problems themselves cause many negative effects ranging from mere procedural inconvenience to patient deaths. The first healthcare provider problem is the nature of the domain itself, which is problematic because it is arguably the most complex profession. It lacks universal standards and state-of-the-art information technology. It operates subject to multi-agency laws and regulations, and is conducted in a disparate array of medical practices and healthcare delivery venues. Principal among these are organizational providers such as hospitals, which operate per common accreditation standards but customize practices and procedures, and professional providers such as physicians, whom, although peer-reviewed and licensed, practice a self-determined mix of art and science of medicine, and which utilizes complex testing and treatment facilities and equipment operated in locations typically remote from practice and delivery sites by third parties, whom, although certified, are not readily accessible for consultation. The second healthcare provider problem is the medicine and healthcare triad. Medical practice and healthcare delivery require an in-depth knowledge of the presenting patient, comprehended by the provider distinctly and separately among the several other patients currently in treatment, the patients presenting pathology or possibly comorbidities, and also the principal provider's care team members and their individual capabilities as they relate to the presenting patient and his or her pathology. The third provider challenge is the time-critical nature of human biology and medicine. Not only must medical practice and healthcare delivery actions be done completely and accurately, but also in a timely manner. And timeliness is required for the intended effects of actions taken in both the micro or internal and macro or external environments to be obtained. Internally, human homeostasis occurs continually, driven by microbiological mechanisms that control inputs and internal conditions in order to maintain a normal biophysiological state of equilibrium. Externally, in the visible world, conditions and circumstances change constantly too, which changes must be detected and reacted to in time to achieve the intended effects. Both of these aspects of timeliness require constant monitoring to detect changing conditions in time to maintain nominal conditions or to prevent unintentional conditions and crises. The fourth provider challenge is the multidimensional scope of healthcare. Notwithstanding the fact that current healthcare is more correctly described as health cure, that is, the return of the morbid patient to the status of biophysiopsychologically nominal and stable person, healthcare should be defined to include the maintenance of good health. Therefore, this schematic depicts 4 aspects, beginning with the womb to tomb or conception to death duration of an individual human life, punctuated by episodes of injury and illness requiring medical intervention, and/or by episodes of inpatient hospital-based care and treatment. Ideally, the information that accrues during the patient's subjective and objective data collection, also known as history and physical workup, the differential and final diagnosis, the case assessment, and the treatment plan, should be archived in a common body of knowledge in a manner that is readily accessible for application to the next case that presents. The fifth provider challenge is personal cognitive characteristics. Patrick Koskari, MD, in his 2009 article entitled Clinical Cognition and Diagnostic Error, Applications of a Dual Process Model of Reasoning, identifies several cognitive impediments that affect us all, but that are exacerbated in clinicians because of the nature of their work and their typical working conditions. These include what he labels as high decision density, interruptions or distractions, circadian dysynchronicity or interruption of biological daily cycles leading to uncoordinated or conflicting psychological and physiological states within a daily time period, fatigue or sleep deprivation, and emotional perturbations, also known as affective state disturbance. Regarding sleep deprivation, it is significant to note that cognitive decision-making tends to reach its nadir at 3 to 4 a.m., and that some studies equate cognitive performance at that time with legal intoxication. The sixth provider characteristic is that of intensive information. Medical and healthcare information typically is intense with respect to its volume, variety, velocity, and varying veracity. Given these extremes of amount, type, speed, and accuracy, it is impossible for the human mind to execute the four activities of the information processing cycle depicted here with the required completeness, accuracy, and timeliness performed continuously. First, to acquire information through constant monitoring and complex event analysis. Second, to assess that information through similarity searches and predictive analyses. Third, to apply information through decision-making and process execution. And fourth, to adapt information through results analysis and process improvement. The seventh provider problem is that of chaotic venues. For example, these two photographs depict the potential cause and effect nature of clinical chaos. In the upper left photo, one nurse at a nursing station is taking report from another, which possibly is erroneous or incomplete because some other clinicians, as highlighted by the red box, are conversing in the same space and in a probably audible and therefore distracting manner. As highlighted in the lower right photo, the hurried and complicated venue may lead to communication using familiar but unreliable and therefore error-prone means of communication such as written notes, rather than the more reliable means such as the electronic health record data readily available via the computer terminal in close proximity, as highlighted again by the red box. The eighth provider problem is the uncontrolled experiment. Patient care and treatment are in fact components of a scientific exercise conducted using the scientific method, beginning with a history and physical workup leading to a problem identification and a diagnostic hypothesis following from a differential diagnosis for a more complicated presentation, and then leading to care and treatment that is more or less experimental, depending on the clinician's familiarity with the presenting problem. However, the clinical case may in fact represent two or more such experiments that are interactive and concurrent, if comorbidity is involved. The one or more concurrent experiments are conducted also under largely uncontrolled conditions in a non-laboratory setting. Experimental continuity and timeliness will be complicated if one pathology, such as type 2 diabetes, is well understood and therefore subject to a sequential course of treatment, but another pathology, such as an infrequently occurring malignancy, is involved and necessarily subject to an iterative course in treatment as new diagnoses are developed and different treatment plans executed. The ninth provider problem is electronic health record systems, or EHRs. The problematic aspects encountered are summarized by the survey results shown on this slide. Efficiency improvement impediments, no significant decrease in workload, and increased operating costs. These disappointing results to date, following more than 3 decades of operational experience, are not surprising, given that EHRs are designed primarily as systems of record with revenue cycle management as their principal design objective. The necessary improvement in IT-enabled data management will be realized by systems of engagement facilitating real-time process management. James Broslow, MD, a retired pediatrician and inventor of the eBroslow app for pediatric medication dosing calculation and administration verification, states a principled caution in medical practice and healthcare delivery to minimize the cognitive demands leading to medical mistakes, that memory and mathematics must be avoided to ensure correct care. However, practitioners traditionally have ignored this advice, probably because it has seemed not to be feasible. Lawrence Weed, MD, a recently deceased American physician, researcher, educator, entrepreneur, and author who is best known for creating the problem-oriented medical record, as well as one of the first electronic health records, states in his 2017 book entitled Medicine in Denial, co-authored with his son, that, and I quote, "A culture of denial subverts the healthcare system from its foundation. The foundation, the basis for deciding what care each patient individually needs, is connecting patient data to medical knowledge. That foundation and the processes of care resting upon it are built by the fallible minds of physicians. A new and secure foundation requires 2 elements external to the mind: electronic information tools and standards of care for managing clinical information." End quote. In consideration of the 9 practice problems previously described, and fortified by the empirical and therefore authoritative observations of Drs. Broslow and Weed, I have arrived at my own conclusion regarding the root cause of medical mistakes. Based on my 4 decades of information technology work experience and my observations in hospitals and other healthcare delivery venues during much of that time, combined with relevant reading, including peer-reviewed studies regarding medical mistake root cause analysis, I postulate the following. Healthcare provider practice problems present cognitive demands that exceed significantly the clinical practitioners and healthcare administrators or managers' cognitive capacity, and thereby creates the real root cause of medical mistakes, cognitive overload. Principally because of the 9 practice problems just reviewed, the summary symptom of current medical practice and healthcare delivery is the potentially dangerous and life-threatening occurrence of medical mistakes. Medical error has been defined as an unintended act, either of omission or commission, or an act that does not achieve its intended outcome, or the failure of a planned action to be completed as intended, an error of execution, or the use of a wrong plan to achieve a clinical aim, an error of planning, or a deviation from the process of care that may or may not cause harm to the patient. Patient harm from medical error can occur at the individual or at the system level. Currently, in the United States, medical mistakes are the 3rd leading cause of patient deaths, following cancer and heart disease, numbering from 250,000 to almost 500,000 deaths annually, depending on the study cited. This is an almost 5-fold increase during the 2 decades since the USA Institute of Medicine to Err is Human report was published, and medical mistakes now account for 45% of the cost of health care in the USA, approximately $1.44 trillion annually. There is no mistake mitigation end in sight for several reasons. First, no international classification of diseases code exists for medical errors or human system factors. Second, morbidity or mortality committee minutes are subject to legal discovery. Third, malpractice claim settlements routinely include gag orders. And fourth, there is no uniform and mandatory investigative or corrective actions such as the USA National Transportation Safety Board and its accident investigation practices. Notwithstanding what I have just demonstrated as the root cause of medical mistakes, cognitive overload, Traditional and currently operating medical mistake mitigation and patient safety organizations continue to focus on human factors such as culture of safety, heuristics for memorization, and training for performance improvement. However, as previously described, medical mistakes have continued to rise at an alarming rate to unacceptable levels in the face of these efforts. Nevertheless, the focus on human factors continues by such organizations as the long-standing Institute for Healthcare Improvement, now merged with the longer-standing National Patient Safety Foundation, ongoing educational ventures such as the Safety and Quality Informatics and Leadership Program at Harvard Medical School, academic centers for patient safety improvement and innovation, such as the Armstrong Institute for Patient Safety and Quality at Johns Hopkins Medicine, and more recently formed foundations for goal setting and healthcare provider and medical technology vendor coalitions, such as the Patient Safety Movement Foundation. By emphasizing standards and practices improvement, typically predicated on resolving the conflicting approaches of developing checklists short enough to enable memorization, with the ongoing progress of medical research that exposes more and more complicated pathology-specific findings for migration from bench to bedside, these organizations exacerbate the root cause of medical mistakes and degradation of patient safety, cognitive overload. The preceding facts, conclusions, and observations lead us to this syllogism. Whereas medical and healthcare practices and procedures are critical and complicated and constantly operating, and whereas medical and healthcare venues are extraordinarily varied, dispersed, and chaotic, and whereas human cognitive capabilities are exceeded by medical practice and healthcare delivery demands, and whereas provider subject matter experts require customized information technology or IT solutions, therefore, healthcare providers need a simple and robust software solution to create real-time IT applications or apps for complete, accurate, and timely cognitive support. The benefit of the required software solution just deduced and described is demonstrated graphically on this slide. Whereas both the traditional and recommended transformative mistake mitigation methods begin with careful process analysis and documentation, the trademarked Robust Process Improvement Procedure, or RPI, of the Joint Commission trains practitioners in the perfected process and requires them to execute it perfectly whenever needed, thus exacerbating the root cause of medical mistakes, cognitive overload. The software solution, however, memorializes the perfected process in a software-coded application or app, and then trains practitioners in the use of the app, thus adding a development step, but thereby eliminating the need for memorization of procedures and mathematics, and thereby tipping the scale in favor of the automated solution by minimizing cognitive requirements. The universe of healthcare provider use cases is virtually infinite, but in general, it is defined by the Joint Commission in its several healthcare provider venue-specific accreditation standards publications, such as the Comprehensive Accreditation Manual for Hospitals for organizational providers in the USA, and also by the plethora of medical practice education and training documents and licensing standards for professional providers. These use cases pertain to both administrative and clinical processes. This schematic depicts the scope of a typical rules-based process in the medical practice and healthcare delivery domain. The process itself is shown as a flowchart in the central light blue plane, which process incorporates staff actors above the plane and system actors below the plane, and which may include automated features such as complex event processing and analytics, as listed on the right of the schematic. Given the foregoing information leading to an identification of cognitive overload as the root cause of medical mistakes, the current status of medical mistakes as the third leading cause of patient deaths, and the wide variety of critical medical and healthcare use cases subject to medical mistakes, My vision for the much-needed IT-enabled medical practice and healthcare delivery transformative solution is encapsulated in the acronym of the solution name: Cloud Healthcare Appliance Real-Time, a functional and dynamic supplement to the structural and static patient chart. Therefore, as noted on this slide, C stands for cloud-based, meaning a secure solution as a service or SaaS suite of software components accessible anytime and any place via an internet-connected secure portal. H, standing for healthcare, designated the domain and the design to support non-functional or system and functional capability requirements of healthcare providers. A, standing for appliance, meaning a software development kit intended for a healthcare provider staff, administrative and clinical, to create customized cognitive support apps. And R&T, standing for real-time, meaning constantly and instantly available to facilitate automation of use cases. To meet the demonstrated need for a real-time information technology solution, these requirements must be satisfied. First, non-functional requirements, typically met by a combination of the hardware and operating system software platforms, as they apply to both the integrated development environment, which is CHART, and to the applications or apps that it creates. That they be ubiquitous, that is, accessible anywhere and any time. That they be secure with respect to data access, data transmission, and data storage. That they be reliable, that is, operate on a non-stop and no-fault basis. That they be scalable, that is, able to garner operating system and hardware resources as needed in response to varying workloads. And that they be economical, which is implemented by CHART by running in a cloud data center and billable on a usage-sensitive subscription basis. The functional requirements, typically those provided by the application software, in this case pertain to the CHART integrated development environment itself. It must be easy to use by non-IT healthcare providers, subject matter experts, to create complex apps and to operate and optimize them as needed. To enable the creation of cognitive support apps and to manage them and deploy them to mobile devices, the CHARTSaaS integrated development environment includes 8 features: subscriber or user administration and the administration of the artifacts that they create, rules-based or Boolean decision description, process or case management description, data and device interoperability description, Bayesian or multivariate analytics description, mobile device administration and management, knowledge archiving and access management, and operations management and optimization of the artifacts. This information technology architecture schematic depicts the several components of the CHARTSaaS solution and their principal purposes. In general, the non-functional requirements, including reliability, security per HIPAA regulations, and scalability, are defined and satisfied by the selected cloud service provider or CSP services enclosed in green. The CSP managed Internet accessible data center also provides services for secure connection to other Internet accessible sources and devices, commonly referred to as the Internet of Things or IoT. The functional requirements provided by components enclosed in blue includes the cloud-based CHARTSaaS integrated delivery environment that itself includes services for interoperability for the CHARTSaaS subscribers' on-premise IT systems and data sources, such as its EHR system. Using the CHARTSaaS IDE, subscribers' authorized users can create applications that can be uploaded to an app store and downloaded to run in the user mobile devices, as shown in red. Access to the Cloud Healthcare Appliance Real-Time Solution as a Service, or CHARTSaaS Integrated Development Environment, or IDE, requires a four-step procedure. First, a prospective CHARTSaaS subscriber completes the registration form at CHARTSaaS.com and submits it electronically. Second, the prospective subscriber receives an email of approval and acceptance, including disclaimers and some instructions, and also including the subscriber's login credentials. Third, the now approved subscriber surfs to CHARTSaaS.com's sandbox page and logs in. And fourth, the subscriber views the Integrated Development Environment desktop and clicks on one of the feature icons to begin app development work. This slide depicts the screens used for describing a process at upper left and also a case at lower right. The Process Design tool implements the familiar swim lane flowchart paradigm, in this case to describe a failure to rescue mitigation process, and the Case Description screen implements the folder paradigm to aggregate discontinuous but related processes that include unpredictable human interventions and/or wait times, as would be the case with a health insurance claim. This slide depicts the screen used for describing a multi-conditional and action decision. The two-dimensional table format includes rows that define the decision parameters by name and the threshold, normal, or other critical values against which the decision input value is to be evaluated, and the one or more actions to be executed depending on the evaluation. This approach would be adequate to monitor a diabetic patient's A1C level and included in a process to notify the healthcare provider and/or the patient for insulin level regulation. Alternatively, required actions can be defined in named columns in order to include several parameter value evaluations concurrently, as would be needed for monitoring of sepsis to prevent potential progression to severe sepsis or septic shock. This slide depicts a screen that defines and provides access to several mobility-related parameter and value definition screens, including authorized users, location, processes to be included, devices or operating systems such as Android or iOS to be targeted, and permitted access to back-end systems such as the subscriber's EHR system. Among the virtually infinite number of use case candidates for automation using the CHARTSaaS IDE, most include one of the following four persistent subprocesses that recur frequently in medical practice and healthcare delivery, that exceed human cognitive capability, and that therefore lead to patient morbidity and mortality. First, failure to rescue, patient preventable death owing to a clinical complication not recognized in a timely manner or treated appropriately. Second, constant monitoring, observation of a patient, disease, condition, or one or more medical parameters over time. Third, alarm or alert fatigue, desensitization to the alarms or alerts owing to exposure to a high number of frequent alarms. And fourth, handoff communication, the transition of care and patient-specific information from one healthcare professional to another. Let us take handoff communication as an example to demonstrate the potential value of a real-time cognitive support app created using the CHARTSaaS IDE. Since handoff communication errors are the leading cause of medical mistakes, they must be mitigated in order to reduce the resulting instances of patient morbidity and mortality. This slide depicts a fatal handoff communication sentinel event using the swim lane paradigm with 5 rows to depict the activity of the 5 actors: the patient, healthcare physician, provider, nursing staff on the postoperative orthopedic nursing unit 1, nursing staff on the receiving cardiac nursing unit 2, and the electronic health record IT system. Also included are 7 columns to depict the 5 events occurring between the beginning and end of the process flow. This fatal sentinel event as reported in the Joint Commission per its accreditation requirements, and published in an April 2015 issue of TJC's publication named The Source, was described as follows. Quote, a healthcare system submitted a root cause analysis, or RCA, to the Joint Commission for a sentinel event that involved a patient whose blood levels were not drawn frequently enough to monitor the thinness of her blood while receiving a continuous heparin infusion. The patient had been started on a heparin infusion on an orthopedic unit and then was later transferred to a cardiac unit. The order set for the heparin infusion was not entered properly, leaving out the automatic order for blood tests every 6 hours. During the handoff report, the nurses did not discuss when the next blood test would occur to monitor the heparin infusion. For 24 hours, the patient went without blood tests until an oncoming nurse questioned the situation during a handoff report. At this time, the off-going nurse also reported that the patient had been complaining of a headache for several hours. A computerized tomography, or CT scan, showed intracerebral hemorrhage. When the patient's mental status deteriorated, the family chose not to proceed with surgery due to the patient's multiple comorbidities and recent decrease in quality of life. She expired 3 days later. End quote. This slide includes representation of the 3 handoff communication app screens. The left-hand one is designed for patient or nursing unit identification. If a nursing unit is identified, the center one is used for automatic display of the current patient roster on the identified unit for subsequent selection of the specific patient. And the right-hand screen is for display of user-selected patient data, organized according to the Situation, Background, Assessment, and Recommendations, or SBAR heuristic. Data pertinent to the monitoring of potential type 1 heparin-induced thrombocytopenia, or type 1 HIT, the values of which are approaching lethal limits and/or require urgent action, are displayed in red. As you can see, CHARTSaaS enables healthcare provider subject matter experts to create customized, cost-effective, and potentially life-saving apps such as the Handoff Communications app with minimal operating expense, no capital cost, minimal IT complexity, and little or no impact on the provider's IT system and staff resources because of the cloud-based portal and subscription modalities of operation. This slide employs the swim lane flowchart paradigm used previously to depict the sentinel event previously described as it might have occurred with a CHARTSaaS-built handoff communication app in operation, depicted in the added swim lane or row of the flowchart at the bottom of the chart enclosed in green. The app operates continuously and is designed to monitor the occurrence and content of updates to the EHR or HIS patient record and to report problematic events. In this case, the app would infer that the required blood type 1 HIT test had not been performed within the 6-hour time interval from the previous test because the app could not detect the occurrence of an update to the patient's EHR case record corresponding to test results data field. Therefore, the app would notify the clinical staff member or members via his, her, or their assigned stationary and/or mobile digital devices of the emergent need to perform the ordered test and to read the result. Alternatively, the app could have been designed to perform the designated data value evaluation also. Thus, the medical error of omission would have been avoided and the patient's life saved. In conclusion, per the presentation objective, I hope for 3 things. First, that you can appreciate real-time information technology-enabled cognitive support as a requirement to accomplish complete, accurate, and timely, and cost-effective medical practice and healthcare delivery. Second, that you will associate with CHARTSaaS LLC to provide funds and/or expertise to complete the development and launching of CHARTSaaS as a usage-sensitive subscription service for licensed, accredited healthcare providers to improve medical practice and healthcare delivery in a systematic and shareable manner that facilitates continuous process improvement. And third, that you will apply CHARTSaaS to obtain significant improvement in lifelong personalized health maintenance, medical mistake mitigation, medical case outcomes, operational economy, efficiency, and effectiveness, and the acceleration of knowledge accrual and application. Thank you for your valuable time and attention to consider the Cloud Healthcare Appliance Real-Time Solution as a Service, Purpose, Scope, and Transformative Potential. Please contact me via email or phone at your earliest convenience to discuss and decide how you may participate to assist in realizing this IT solution for the medical practice and healthcare delivery problems of medical mistakes, patient safety, suboptimal case outcomes, and knowledge management. Good wishes for another great day and continued success in your own healthcare-related activities.